Well, welcome, everybody. It's my pleasure today to welcome Dr. Nauman Ashraf. He's the program director for Ozark Center Psychiatry Residency program in Joplin. He's worked there since 2013, treating patients with mental illness and comorbid substance abuse. He's also served as the medical director of addiction services at the Ozark Center. He started the Opioid Based Outpatient Treatment, or OBOT clinic at the Ozark Center in 2017, oversees patient treatment for opioid use disorder using Subxone and other standard of care therapy, which we'll talk about. He has a degree from medical and health sciences from Pakistan and New York University, where he completed both psychiatric residency and fellowship in addiction psychiatry. Board certified psychiatrist, as well as addiction psychiatry, is a recipient of numerous awards. And welcome Dr. Ashraf to the room. Dr. Ashraf, take it away.
Thank you. Okay, good afternoon, everyone. So we'll talk about opioid use disorder, and then in the end, we'll talk about one of the studies that we did, or one of the surveys that we did based off of our clinic. So let's begin with it. I'll talk about what I'm going to cover. Just wanted to say a little bit about the STR grant. SAMHSA is one body that you probably know. They received federal funding to fight with opioid epidemic. And then SAMHSA started the opioid response network and provided the funding to all the states. And I am one of their consultant prescribers. So if any one of you who believes that you guys need to start an OBOT clinic or the opioid treatment program, or you have a patient, you need some consultation, there's a network you can reach out. You can Google it, you can go through SAMHSA website, and in Missouri, and you will reach the transfer technology specialist, and that would connect you to one of the consultant prescribers, and that they can help you with that. So just wanted to say that. Okay, my objectives for the talk will cover the epidemiology, historical background, how we got to the opioid epidemic, and the neurobiology of opioids, and try to understand the treatment modalities that we have available for opioid use disorder. And then I will finish it off with a survey we did about the barriers to prescribing Subxone in our emergency department. And just wanted to understand, because we had found out that we were not prescribing it a lot. The patients who had opioid disorders, they would be discharged without one of the evidence-based treatment, which is either Subxone, methadone, or referral to those treatments or Naltrexone. So we wanted to understand why it was happening. So we did a survey. I'll go through that. What is a substance use disorder? And it can be any substance use. In this case, will be opioid use disorder. It's a primary chronic brain disorder, which is characterized by compulsive substance-seeking behavior and use despite harmful consequences. And basically, it's the loss of control over drug use. What people start off, it starts off as a positive reinforcement phenomena where they use the drug, they get release of dopamine, they feel great. So they keep using it because of that. But then it shifts to the point where it turns from positive to negative reinforcement. And in that stage, if they don't use the drug, they have very bad withdrawal symptoms. And because of withdrawal symptoms, they're not able to concentrate, function, not able to do anything in life because they are withdrawing all the time. So then they use drug just to quote unquote feel normal and they can get about their life. So that's the stage where you lose control over drug use, and that's probably the basic definition of any addiction: loss of control over drug use or over the behavior. This chart basically shows the relapse rate. So if you look at different disorder, and the comparison is done which to show that substance use disorder should be treated as just like any other medical problem, because it's not something that happens and you treat it and then after that you forget about it, or the bigger stigma that we have in the community that it's a moral illness. Okay, you have a substance problem, go see a priest or get help from family and just better yourself. But we understand it as a medical illness. There's a medical model. There are changes in the brain in of these people. So it should be understood just like any other disorder. So if you look at diabetes, you have a 30 to 50% relapse rate. Hypertension, 50 to 70. Asthma, 50 to 70. Substance use disorder 40 to 60. But unfortunately, when someone comes back to the hospital or comes to a clinic for with hypertension, diabetes, we try to figure out how we can help them best, how we can find out ways to, so for those people, so they're not non-compliant in the future. But for substance use disorder, the attitudes are different. So that's why it's important to highlight this, that it should be considered as just like any other illness, has a biological basis, has the relapse rate, is a chronic disorder. How do we diagnose any substance use disorder? In this case would be opioid use disorder. There are 11 criteria in DSM-5, and you just need 2 now to diagnose it. And then for the severity, if it's 2 to 3, it'll be a mild disorder, 4 to 5 moderate, and if you have 6+, it's a severe disorder. Why do you have to strategize? Because then your services will depend on that. If it's a severe disorder and somebody has more risk, you may want to consider inpatient rehab versus outpatient treatment. So it becomes important to find out where they're at. So failure to fulfill responsibilities, if someone is using drugs, and you need to understand how they spend their day. So they get up in the morning, they're probably withdrawing from the drug they took last night. So they need the drug in the morning. To obtain the drug, they need money. Either initially they have the money, then they run out of their balances, have balance on their credit card, then they start asking their friends, family members, steal, lie, cheat, whatever it takes to get the money. Then they have to find a dealer, obtain the drug, use it, and then recover from it. So doing all this, they are not able to get up and go to either school or go to work. And that's the problem with this disorder, that they're not able to fulfill their responsibilities. Use in physically hazardous situation, like someone who is operating a machinery, somebody who's driving and they're intoxicated. Legal problem used to be a criteria in DSM-4, but was taken out and replaced with cravings, because research showed the craving was a better criteria to be here. It's just a desire to use. Social and interpersonal problems, these people run into those issues because they ask for so much help. Sometimes they cheat, lie, and that's sort of part of the personality that someone who is struggling with addiction develops. They use larger amounts or longer than intended. So initially they will start off with a smaller amount, but the desire is more and more, and like the drug, they start using more and more. They try to cut it down because they know it's causing problem in their personal life, professional life, but it's hard because, again, it's a brain disorder where they need the proper treatment. It's not in their control to just stop it, because they start having withdrawal symptoms if they stop it. They spend more time to obtain it, use it, and recover from it. They give up their important activities or parts of life. There's ongoing use despite problems. They know there are issues. They know their kids are in the DFS custody, or they have legal problems, or their marriage is falling apart. Just cannot stop it. Tolerance, again, start with a lower amount, then the receptors get saturated. They need more and more drug. So tolerance increases. Withdrawal, if they abruptly stop it, the example I gave, when they get up in the morning and the drug is getting out of their body, they start having withdrawal symptoms. And we'll cover the withdrawal symptoms in the slides later on. So, but if someone is prescribed opioids, now these drugs will make any person dependent who takes them for, say, 3-4 weeks on a good dose. They will become dependent. If they stop it, they will go through withdrawal. So if someone who was prescribed for some reason, like they had a hip fracture, and they stayed on it, and now it's harder for them to get off of it, if you want to diagnose a use disorder in them, then you won't count 10 and 11, because that can happen just with the prescription used to, even when they took it the way it was prescribed. The use disorder is basically the maladaptive behavior of addiction, which happens where you are you're using it in, like, say, when you're driving, or you're getting into other troubles, not keeping personal relationship, lying, cheating. When you have those behaviors with it, then it becomes a use disorder. Just going over the stats, we have more than 130 people in the US that die with opioid overdose every day. We make up about 5% of the world's population and consume about close to 80% of the treatment opioid prescriptions. Treatment opioid drugs contribute to 40% of all US opioid overdose deaths. System impact, I want to talk about this because why it's important to fund opioid treatment and treat these patients who are struggling with the problem. Every single dollar that we spend on substance use treatment saves about $4 in healthcare expenditure and $7 in criminal justice costs. Think about these people. Either they will end up in the healthcare setting because they're using, contracting diseases, IV use, Hep C, HIV, or they're overdosing and they'll be brought to the ED and medical floor and psych floors, or when they are using or they are transporting the drug and they have possession of drug, they will have criminal charges, they'll end up in the forensic system. So as a overall, if you look at economic point of view, we are spending more money by not treating it. It's better to treat this problem. And now we know that there's a medical basis, a disease, a process, so it should be treated. So I just wanted to mention that. What is the neurobiology of addiction? This brain circuit shows, I think everyone knows about the painkiller effect of the opioids. That's through the thalamus. And then they also act on the cortex, where they cause impaired balance. Prefrontal cortex is an important area that assigns the salience to the drug. So how important is the drug, whether I should use it or not. And then the area in purple is aloof from VTA to nucleus accumbens, which is ventral tegmental area in the brain, where drug binds to the mu receptor and then releases dopamine in the nucleus accumbens, which most of the, all the drugs of abuse will release dopamine. That's their main final common pathway to cause that pleasure that goes with the drug use. So this is an important loop in terms of why they keep on using the drug and they feel good. When in normal people, you would have your cortex and prefrontal cortex pretty strong, so they will provide inhibitory control. And that's why a lot of people don't use, because they know it's bad and your cortex is telling you. But when you start using it, the lower cortex, the limbic cortex, takes over and hijacks the system. So it grows in size and your prefrontal cortex diminishes. So then you have more of like an animal brain, where if you want something, you want something, and then go and use the drug. What is the history of opioid in our country? So in Civil War, if you go back there, what happened was they introduced hypodermic needle at that time. And drugs like morphine, potent analgesics, they were available, and they were even prescribed for, say, minor problem like menstrual pain, menopausal symptoms. Doctors will prescribe opioids for that. And the needle was available. So people started shooting at that point. That's where it started. And then it increased. And then in 1914, Harrison Act was passed, where they prohibited all the prescription narcotics. So they told doctors that anyone who is struggling with the disease of addiction, if you prescribe opioids to them to treat them, then you will be prosecuted. And a lot of physicians were prosecuted because some physicians believed it was a disorder they had to treat, that was in the best interest of the patient. But the government told them they could not, because they were increasing the addiction. So physicians were prosecuted and they feared opioid prescribing. That led to the drug trafficking and criminal behavior that we have seen with marijuana before the decriminalization. The same thing happens. Alcohol, whenever you prohibit anything, the criminal behavior goes up, the drug trafficking goes up, then you're dealing with another forensic issue. So it's better to treat the disorder than try to suppress it, because people then find ways to get the medication. So then in 1974, they opened a first methadone maintenance program for opioid addiction. And then in 1990s, another phenomenon happened, which was there was a large increase in prescription opioid medication. So the prior one, we talked about Civil War and all, we had more of like heroin, morphine, those compounds. And now you're getting into these pain pills. So in 1990, Purdue Pharma came up with a pain medication. And they said that this medication will treat the pain only and will not make people addicted to it. So that's what they told. And all the doctors were like, well, that's great. We want to treat our patients. But also around the same time, how it happened, somebody needs to figure it out. They also added a fifth vital sign to the four existing vital signs. So pain was added to your temperature and respiration and blood pressure. So now if you are on call, say, and a nurse calls you and says, hey, patient is saying he has 1 like 8 out of 10 pain, but normally if you ask them, it's always 15 out of 10. So if they say they are hurting, nurse would say, it's one of the vital signs. We have to ask every 6-7 hours, what do we do? How do we treat it? Well, you have the drug that Purdue told you that it's not going to make them addicted, take away the pain. So people started prescribing it a lot. And then later they found out, no, the drug was addictive. And now we have another problem at our hand that we are dealing with. So then I think Purdue Pharma settled the lawsuit, but that's how we got to this point. So in 2000, they passed the Act, Data 2000, that allowed office-based treatment of opioid dependence. And that's when physicians were allowed to prescribe Subxone from their office setting. Now we'll talk about why there was a need, because we already had methadone, but why we needed Subxone, I'll talk about in the other slides, but that's some of the history when in 2002, Subxone became available. And CARA Act in 2016 recently passed that also allowed nurse practitioner and physician assistants to prescribe buprenorphine. There's some requirement they have to fulfill that, but they can prescribe it so we can fight this epidemic. What are the different approaches of treating someone who has opioid issues or opioid use disorder? So traditional model was opioid dependence. They come in to the hospital, you do detoxification, and then you discharge them with counseling, but you do not use any pharmacological support. That was the traditional model. What was the problem with that? Medication-free approach can be effective for small group of subgroup of stable patients with high motivation. So it was a very small group that would respond to it, but about 90% of those detoxified will relapse within first 1 to 2 months unless treated with medications. And we'll cover those medications that are approved, FDA approved for the treatment of opioid use disorder. And some patients, this was another problem. So 90% are relapsing, and some of them, when they relapse, they will die as a result of overdose. So we talked about tolerance when we went through the criteria. When someone starts using drug, if you ever take history from any person who's struggling with drug addiction, they would tell you, yeah, I started off with, say, talk about heroin, I started off with quarter or a line, and then I went up to like a half a gram, 1 gram, 2 gram, increased it. So suppose someone comes to you and they say, why shoot up about 4 grams a day? You keep them in the hospital for 5 days, detoxify, you send them to a rehab program for 30 days. They come out now their receptor tolerance has changed, because when they were using 4 grams, their body was adjusted to it, and specifically their breathing center, the respiratory center, was adjusted to it. Now when they go back, we have brought their tolerance down, but their psychological memory is the same. Well, I can shoot 4 grams. They go out, they try to shoot that, and they die because of respiratory suppression. So that was the main issue with this approach. A, very high relapse rate without medication. B, overdose risk. Residential treatments, I mentioned that the older approach was you detox them, send them to residential treatment. What are the problems with that? There's a high failure and dropout rate from the therapeutic community, which is one of the type of residential treatment. Up to 50% dropout during the first week after detoxification. Requires significant investment of time, because you have to go over there for 30 days, 60 days, 90 days, and you have to pay for some of the facilities. So there's a financial burden, disruption of other domains of educational, social, or occupational functioning. When they're discharged from controlled environment without agonist or antagonist on board, it is associated with significantly heightened risk for overdose death that we just covered. So what is the standard of care now? So these days, the standard of care is medication-assisted treatment, which is the use of medications in combination with psychosocial or behavioral therapies as part of an individualized approach to treat patients with substance use disorder. So you're going to use medication and therapy. So the older model was you were just going with the therapy, no medication, but the people are still having cravings and there was a risk of relapse. So now you're taking care of that part by giving them the medication and you provide the therapy with that. What does it do? It enables an individual to reduce or eliminate drug use, addresses associated physical or mental health problems, restores the patient to maximum functional capacity. That is the goal. The goal is for them to get back to their life, to get their life back together, get the job, get their kids back if they're in DFS custody, their marital problems, resolve those, get back to their friends and family. That's the goal. That's what you talk about in therapy once they're on medication. How do they get all that back together? So what are the medications that are approved by FDA? There are three medications. There's a full agonist, which is methadone. Partial agonist is buprenorphine, and antagonist is naltrexone. And there are psychosocial treatments, which is motivational interviewing and the CBT, cognitive behavioral therapy. And then you have to treat the co-occurring psychiatric disorders. For this talk, I will talk about methadone, buprenorphine, naltrexone more. We will not touch upon motivational CBT, but basically motivational therapy is the type of therapy that you are giving more control to the patient. Patient drives the therapy and you are the facilitator. You, as the patient, what are your goals? Why do you want to be sober? Why do you want to be on this medication? What would it do for you? How would it improve your life? Have them come up with a plan. That's motivational, as opposed to the older therapies or older ways of dealing with the patient, which is more of a prescriptive, where the patient comes and tells you and you like, okay, yeah, this is what I'm going to recommend you. This is a great medication, take it and you'll get better. Doesn't work with, especially with patients who are struggling with addiction, but I think it doesn't work with any patient. There's a lot of non-compliance and even other medical disorder if we use the prescriptive way of dealing with our patients. So the best way would be motivational. CBT is a cognitive behavioral therapy. We believe our thought process affects our behavior, that affects what we do. So you want to change their cognition from pessimistic thoughts to optimistic thoughts, and then that hopefully will change their behavior. So we talked about full agonist. The full agonist is the one that binds with the receptor and has 100% intrinsic activity, will activate this receptor fully. So you can say about 100% activity on that receptor. Partial agonist is buprenorphine that will bind with all the receptors, will only activate 45 to 50% of the receptors. Naltrexone has no intrinsic activity, that will bind with the receptors, but will not activate the receptor. So let's talk about agonist therapy, which is a full agonist is methadone, partial is buprenorphine. The advantages, they have constant stimulation of opioid receptor that stabilizes the system's functioning, prevents withdrawal, relieves cravings. See, those were the issues that we were dealing with. Those were their goals for the treatment. No cravings, no withdrawal. They can feel quote unquote normal and then go about their day. It stabilizes the effect, blocks effects of other opioids. Now this piece is very important, blocks the effects of other opioids. So if you have any of these three medications on board and they are on the receptors, they have a very high affinity. So if someone has a relapse, which is part of recovery, as we saw 40 to 60% relapse, if they use anything, heroin, morphine, oxy, these medications will prevent those medications, the drug of abuse, from binding to the receptor, which means it will prevent the overdose death. So that's why it's very important for these patients to be on one of these medications. Reduces drug-seeking behavior, allows opportunities for the patients to begin behavioral changes and address other problems. What are the limitations for methadone and buprenorphine? You have to have regular oversight, which is more for methadone and less for buprenorphine. So I was talking about why we needed buprenorphine. The problem with methadone is highly regulated because it's a full agonist. So if they take too much of it, they can kill themselves. They mix it with alcohol, benzo, they can kill themselves. Buprenorphine is a little bit safer drug. It's a partial agonist and has a ceiling effect. We'll get to it. So for methadone, you need to have a methadone clinic for addiction purposes. Now, methadone and all these medications are also prescribed for pain purposes. They have separate regulation. But for addiction purposes, if you want to prescribe it for that substance use disorder, then you can only prescribe methadone from a licensed facility. And for the first month, for the first 3 months, they have to go there every single day and be involved in the therapy. And after a year, they're able to take 1 month medication home. Also, like if you look at Joplin, I think we only have one program in Joplin. There's one in Miami, maybe. There's one in Galena. They're opening up, or Seneca. But there are not many programs. So if you go there, there are other people, they would know you are there for methadone. So there is this factor of shame involved in that. So a lot of people were not going there to get treatment. that issue, then highly regulated, it's a potent agonist, and you cannot prescribe it. So buprenorphine has the advantage where any doctor can do a course, 8-hour training, get a waiver, and they can prescribe from their clinic. So I can see them as a psychiatrist, internists can see them, anybody can see them if they have buprenorphine waiver and prescribe the medication. So nobody knows if you went to see your doctor for hypertension or for substance use disorder, and you can get the medication. Also, buprenorphine has fewer side effects because it's a partial agonist, and it has a ceiling effect, so it's safer than methadone. What ceiling effect is, suppose you have a car and that can only go up to 80 miles per hour. So it doesn't matter how much you press on the race, it's not going to go above that. Because of the partial agonism, since it has 45 to 50% intrinsic activity, it's going to block all the receptor, but not going to give you that too much of acceleration or too much of kick, which methadone can do. So it's safer in that way. It's very hard to overdose on it and very hard to die from it. So that's another advantage for using buprenorphine. There's a risk of misuse and diversion with both medication. Of course, they have agonist properties. They're going to give people high, so they have a street value. So they can be misused, they can be diverted. Naltrexone is an antagonist, bind with the receptor, has no intrinsic activity. It will prevent activation of opioid receptors, which has stabilizing system, stabilize the system functioning, blocks effects of exogenous opioids and redevelopment of physical cravings. So will help with the craving, will prevent the overdose effects and stabilize the system. What are the limitations? It can only be administered after opioids are stopped and opioid withdrawal resolves. So it's an antagonist, which means if someone has just used any drug and it has a very high affinity, we already talked about, for the receptors. So if you give it to the patient who has just used, say, morphine, it's going to displace all the morphine from the receptor, which means it's going to put them through withdrawal. So they will feel really bad, having nausea, vomiting, diarrhea, muscle ache. So what you want to do, you want to time it. If you want to give naltrexone for short-acting opioid, you have to wait for 5 to 7 days. For long-acting, maybe 10 to 14 days, and then you can give it to them to prevent the withdrawal. And why you want to prevent it? Because if they take it and they feel bad on it, you kind of eliminated one of the options for the future choice, because patient is probably not going to like the medication. So you want to time it right. If used prior to that time, will cause precipitated withdrawal. Methadone has dominated treatment of opioid dependence in the US. More than 260,000 patients are on in the methadone maintenance program. Advantages to methadone, highest retention rate. Now, methadone is the full agonist, 100%. So some people, their addiction is not controlled with buprenorphine, or some people like it, or some people have comorbid addiction plus pain issues, so they like methadone. So the retention rate, because of that reason, is really good, 80%. Of course, all these strategies are going to reduce HIV, Hep C, Hep B, all these infection rates, because people are not sharing needles anymore because they're getting the medication through a prescriber, which will stabilize their opioid system, so they don't have to go find a dealer and use drugs to stabilize the opioid system. Disadvantages, as I talked about, settings for methadone are restrictive and highly structured. The problem with all these medications is going to be they will maintain physiologic dependence. So you will be dependent on methadone and Subxone, not on naltrexone, because they both have agonist component. So when they want to go off of it, it is hard and it takes months to get them off of it. It's possible, but there is that component of physical dependence. Methadone, stigma about methadone is perceived by many as substituting one addiction for another. A lot of people don't want to prescribe, doctors or patients don't want to take, because they say, well, I was taking heroin, now you're giving me methadone, so what's the difference? It's going to make me dependent again. Again, as I said, it's not about just replacing medication, it's about treating the maladaptive behavior, because when you were using heroin, you would get up in the morning and you would find out where to get the money and find a dealer and then use and recover. You don't have to do all that. You get up in the morning, you take the medication prescribed by your doctor, you go to your work or go to your school. That is what we are doing. We're not substituting one medication with the other. We are treating a disorder. Segregation of methadone maintenance from the rest of healthcare versus medical model treatment as an illness. So the problem with methadone, as I mentioned, you have to go to a clinic. So that segregates it from other. Whereas with buprenorphine, it's nicer. You can go see your doctor and get it. So If we can somehow integrate it with other models for addiction, that would be great. But I think it will be harder. We still have a stigma in the society. We still have a stigma with the hospital administrators. If you talk to them about opening up a methadone clinic next to their medicine clinic, we'll see how that goes. So patients in methadone program report secrecy, shame, sometimes leading to dropping out of treatment. We touched upon that there's a huge component of shame because other people would know why you're there, and then they would start going over there. Buprenorphine naloxone is a long-acting partial agonist, became available in 2002 for office-based prescribing. The retention rate here is about 40 to 55%. Methadone was 80% over 3 to 6 months. Induction is a modest barrier. Patient must wait 12 to 18 hours after last use of short-acting opioid. As we discussed in the Naltrexone I was talking about, that you have to wait out because it's an antagonist. It's going to replace all the drugs on the receptors and precipitate withdrawal. Similarly, buprenorphine is a partial agonist. So it will also displace all the drug, but it will have 50% effect. If they have just used it and they had 100% agonist, they will still go through that 50% withdrawal. So how do you do it? You just time it. You wait for it, and there's a clinical scale called COWS will cover it that you use to find out if someone has the 50% occupancy in the brain at that point, and then you can give the first dose of it safely. That's called Subxone induction. So COWS scale, clinical opioid withdrawal scale, is used to find out when to dose Subxone. And when they are above 10 to 13, the score of 10 to 13, then you're safe to give the first dose. I always start with a low dose. What are the withdrawal symptoms that you would rate is resting pulse rate, sweating, restlessness, pupil size, bone or joint aches, runny nose, GI upset, tremor, yawning, anxiety, irritability, goosebumps. What are the advantages? We said it's a less restrictive prescribing rules. You can do it from your clinic, less risk of overdose, less risk of ventricular arrhythmias. Also with methadone, it increases the QTC interval, so that can lead to arrhythmias, whereas Subxone or buprenorphine does not have that effect. Milder withdrawal symptoms, when people stop it, then the withdrawal symptoms are milder because it's 50% of the methadone. Challenges with buprenorphine, against risk of diversion and abuse, same with even with methadone. Optimum duration of maintenance unclear. High 80 to 90% relapse when discontinued after less than 5 months. So people come in and ask, how long do I have to be on this medication, doc? And that's a good question. And my answer is always, and I try to keep it fairly sort of a medical model. I just tell them, well, if you had hypertension, what would be your answer? So if they have hypertension and they were on antihypertensive, if they can lose weight and they can control their diet and their blood pressure is good, I think they can go off of it if their lifestyle has changed and the blood pressure is fine. Similarly, if they've been on buprenorphine or methadone and they've taken care of the issues that got them to there, so they have their kids are back, their employment is back, their families are happy with them, they have no legal issues, everything is taken care of, and they were able to show that they are engaged in treatment and they can take care of the triggers if they happen. Yes, that's the time to taper them off safely and they can go off of it. Usually I would say at least 1 year for someone, because it takes time to take care of all those issues and get stabilized. It requires a special training, and you need a DEA waiver, which is 8-hour training, and then the DEA will give you a waiver to prescribe it. It's an X number, which is just like your DEA number. It's a separate X number that they give you. Antagonist treatment is the Naltrexone. It's available in oral form and also in the injectable form. Approved by FDA in 1984, and 2010 was the injectable form. Blocks opioids without agonist effects, incompatible with ongoing illicit opioid use, because if they're using and taking Naltrexone, that would put them through withdrawal. No tolerance of withdrawal because it does not have the agonist effect. So if there's a patient who says, well, I don't want to be dependent on anything, then you have the third option, Naltrexone. So you just give that to them, at least save life, decrease their cravings. Induction requires abstinence for 5 to 7 days from short acting like heroin, 7 to 10 days from methadone long acting. Oral form taken daily 50 milligram, or you can then switch them after 2 or 3 weeks to 380 milligram IM injection. The only problem is the liver function test that you have to monitor, but otherwise pretty safe medication. It blocks all opioid receptor. You can consider it in patients who have failed agonist treatment, patient confined to environments that do not allow for medication treatment. So like in forensic setting, in certain rehabs, they don't allow agonist treatment. So they won't allow anyone to bring their buprenorphine or beyond methadone. So then naltrexone can be used. Patients who do not have access to agonist treatment, patients with high risk of diversion, somebody you had in the clinic, but you know that person has failed, has relapsed, and has been selling drug, but you still want to give them options for treatment. Naltrexone may be good. Patients who are highly motivated and willing to taper off opioid agonists, patients who do not want to be treated with an agonist, patients with concomitant opioid and alcohol use disorder. So naltrexone is also approved for alcohol use disorder. If someone has comorbid, it'll be a good drug for both. I want to talk about naloxone or Narcan kit. You may have heard about it. It's a life-saving medication. If someone overdoses, so if you find someone, say, and they are unresponsive and they have blue lips and blue nails, and you look at their eyes and they have pinpoint pupil, you suspect the opioid overdose. And how do you save? By using Narcan. So all our EMS people have Narcan on hand to go and save lives. Pure antagonists at the mu receptors. First responders should have it, family, friends, public patients, family, nurses. So anyone who has opioid use disorder, their family or friends should carry it. If it happens, they can save life. The patient should carry it. Even if they don't use it on themselves, they can save someone else's life. Should be co-prescribed to all with OUD and opioid use disorder and should be given to their family and friends. In Missouri, and I think in most of the states, you can get it from the pharmacy. You do not need a script for it. Tens of thousands of reversals since treated. Okay, so that brings us towards the end, towards the survey. I think I got 7 more minutes. So we wanted to do a survey in our emergency department because we did another study where we found out what was the prescribing pattern, how many people were being diagnosed with opioid use disorder, how many, because we went through their history, we went through their urine toxicology, if they had opioid positive, how many were counseled, how many were started, and the rates were very low. So we wanted to find out why. What are the barriers? Why physicians are not prescribing? So we came up with this survey we did in our emergency department at Freeman. So it asked about the male and female gender. We had about, I think, 8 male and 9 female, total of 17. And there was no non-binary. We asked about their number of years as a practicing provider, average about 4 or 5 years, and whether they were wavered or not. Nobody was wavered. And we asked the questions, if you had lack of belief in effective agonist treatment, if you didn't just really believe in it, that Subxone methadone works. If there was lack of education regarding Subxone as a method of treatment, lack of training on how to initiate Subxone treatment, lack of confidence in the ability to manage opioid use disorder. So if you initiated, did you think that you had to manage it, and that's why you were not going there, or there was some reason about that you didn't feel comfortable managing this disorder? They were time constrained because ED physicians are very busy and they just want to take care of, okay, we took care of the overdose and then maybe send them to someone else. Concerns about diversion, patient reselling the drug. Were you concerned that if we start them and if we give them a script and for 3-4 days to go and follow up with the Subxone program, would they sell it? Was that a concern? Lack of mental health specialty or psychosocial support in the community. Did you not know about any referral source or who to send these patients to? Believe that reimbursement rates are not substantial. Was that a factor? Any religious belief that hinder prescribing Subxone. So if there was any reason that played part into the stigma, some people are very strict religiously. They don't use drug. They don't like to use drug, but was it clouding their judgment as a physician? Need for adjunctive counseling. So did you not start because you know that they need counseling and you don't have any referral source? So we just want to ask them all those questions. Have you encountered other barriers not mentioned above? And I'll share the results with you, what they responded on the survey. So we had this open comment, right? And so those are the ones that I've taken that were very interesting. And forgot to include that graph. Yeah, they also, in terms of these answers, mostly they said that they did not have the good resources available that they knew about in the community, that they could do it, and also the time constraint was an issue, and training was a problem too, that they were not trained to do it. Those were the 3 main responses that we got. Now, these written responses were very interesting that they put down. We do not prescribe out of ED, maybe good referral source. So they're like, we could refer it, they were open to it, but they do not prescribe it. Certification to prescribe, lack of ability of follow-up, overuse of emergency department for non-emergent medication management. So they were also concerned about, oh, we have to do the waiver, we have to do certification, one more thing. Then we don't have follow-up because it's an ED. Our doctors cannot follow up. And then if we start doing that, then people will come back and ask for it and abuse the ED for opioid prescription, which is pretty valid concern that once they know, then they will come, all the patient will come and say, hey, I'm withdrawing, or they can fake some symptoms, I'm in the withdrawal and I need my medication. I do not feel the patients are appropriately managed on Subxone. Specifically, they are not taken off in a timely manner. I also do not feel there's an appropriate social support. So this provider believed that they did not know there was appropriate social support, and also they believed it's kind of a substitution of one medication with another. So we put them on it and they stay on it forever and it's not taken off. Not adequate follow-up from ER setting, the same thing we covered in the other comment. As a nurse practitioner in Missouri, we are unable to prescribe Subxone. So again, lack of not being aware, because we did this research survey recently, like last year, and in 2016, CARA Act actually allowed the nurse practitioners and PAs to prescribe. And in this survey, we included providers, so that had the nurse practitioner and the doctors. I strongly believe emergency providers should not engage in managing chronic problems. So they see it as a chronic issue. They don't want to deal with it. They want to take care of the acute issue and send them to another referral source. It would be like psychiatrists managing diabetes. I will never prescribe Subxone. So that was a pretty hard comment, that never prescribe Subxone, even though we know it's a life-saving drug, even though we know the relapse rate is about 90%. This patient you're treating in the ED will go outside, may use drug and die the next day. And still you have the view that I'll never prescribe it, or I don't feel comfortable. So these are the things that we found out. And the next phase of the study that we designed was to get back to them and do education around it. And maybe hopefully some of them would be willing to do some waiver training and help them use Subxone and be comfortable using it. But then again, we were planning it and then COVID hit. So everything is on the back burner right now. But that would be the next second phase of the study. So take-home points are: substance use disorder, opioid use disorder is a treatable chronic brain disorder. FDA-approved medications are the standard of care for treating opioid use disorder. People can and do recover from opioid use disorder, other substance use disorder. This is the resource medication for opioid use disorder. It's called TIP 63. It's available on SAMHSA. It's the Bible for it. It's got everything that you need to know to treat opioid use disorder. There's also a mentoring program. If someone needs help, PCSS, they can contact them and they can also get help from them. And then it's time for questions.
Okay, thank you so much. I appreciate that talk more than you know, because student doctors are in the room, and you and I are endeavoring to layer OMT on top of the standard of care, Subxone plus patient counseling. I wonder if you could say a few words about our impending study that we hope to launch next semester.
Right. So as Jeff said, that we were thinking about how to improve the functional outcome in these patients and sort of achieve our treatment goals. What else can we do with this medication? So we have observed in the treatment that there are still some patients who are struggling with some side effects. So headache is, say, one of the very common side effects of buprenorphine treatment. Or a lot of patients who have comorbid problem, and that's how they start using pain pills, because it started off with, say, back pain or some other pain. So we thought, what if we can include another layer of treatment in this and see if we can get some effectiveness and treat these issues. So we had designed a study where we would be providing them some OMT treatment, and we hope that that would help with some of the side effects of the treatment and the pain disorder. So we are in the process of sort of finishing up the last pieces, and hopefully thinking about starting it in February around that time.
Dr. Wolf, your hand is up.
Yeah, so thanks. I enjoyed your talk very much. I had questions related to what kind of patients you're actually seeing. You know, it makes sense to me that people that were prescribed opioids might become addicted to them if they took them for an extended period of time. But what are the motivations for your other patients to kind of start in this area or things along those lines? Because we teach our students that the brain matures and that, you know, it takes to about 25 before it's fully matured. And to some extent, you know, I teach, for example, that vaping is dangerous for young people. But I'm curious, when you're sitting there now and you're actually encountering patients, how young of patients do you see that have developed an addiction outside of pain relief? And also, to what extent has the tornado perhaps impacted what you're seeing?
Okay, yeah, it's a good question. So most of the patients that we see that are not, so there's a subset that you said is going to have comorbid pain, right? So those are the ones they were prescribed and then they became dependent, they liked it, and they started using. So that's a separate subset that can happen at any time after the injury. Older patients, younger patients, middle age. Now the ones that have pure opioid use disorder, for them, majority that I have seen, they start in their teenage years, majority of them. The first experience is either, and most commonly, I think the first experience is in the school where they were recreationally, they tried it, they liked it, they were fine, they got off of it, and then it was either a peer pressure that kept it going or they had some sort of medical event. So after that, about 17, 18 is the age where I had my, like a dental issue going on, or was in an accident, and then I was put on opioids, and I liked them, and I could not get off of them. And then it then went from pain pills to Dilaudid, and then heroin, and then other things. So that, I think they pretty early, they start in their teenage years.
Any more questions for our speaker? Go ahead, Dr. Wolf.
And I was curious what your thoughts are on medical marijuana and to what extent you think that that's going to be a gateway drug.
So for gateway there's a debate about it, whether it's a gateway drug or not. They say it's a gateway because the first drug that people use is marijuana, and then it leads to other drugs because now they are open to that drug world, right? You're obtaining it, and then you know about other drugs, and you like it, and you want to try other things, and you experiment it. But that's the same comment that can be made for anything. So if someone used nicotine as a first drug, that would be their gateway drug to alcohol or others. If someone had hands on their pain pills, that would be their gateway drug. Marijuana has more sort of comments about being gateway drug because it's the most commonly available drug, and in our high schoolers, it's 8th graders, that the rates are rising. So that happens to be the first drug they use, but not necessarily the drug that's going to prime your brain for other drugs. Any drug can do that. Any drug can be the gateway drug.
Thank you.
Well, you asked about the medical marijuana. So that's again a separate topic and an interesting one. At this point, you know, we don't know the dose of medical marijuana the way we prescribe other medications. So suppose if you come to me and ask for, say, sertraline, I know the dosages. I have to start at 25, 50, go up to 100, 150. There's a dosing schedule. Medical marijuana, you don't have a dosing schedule. That is the problem right now. So we need more research for us, actually, for physicians to be comfortable to prescribe. Does it have benefit? Of course, there is a huge body of literature that has shown pain benefit, sleep benefit, of course, in the HIV-related wasting syndrome, and those it's approved for that. Chemotherapy-related nausea, it's approved for that, like the Marinol and other forms. So there is a use and utility, but we need more research so we actually know what we are doing. What is the disorder? What is the dose? For how long we need to keep them on? That's the piece that's missing. So that's why a lot of physicians are uncomfortable really prescribing medical marijuana.
You start to see anecdotal stories on Google News or whatever that opioid use in states like Colorado have diminished since legalizing. Dr. Howe, I'm sorry, Parker Howe, you have your hand up. Go ahead.
Hi, yeah. So I'm a first-year medical student. Thank you for your talk. Really enjoyed that. I was just wondering if you could talk about anything that you've seen in terms of literature as far as how the COVID-19 pandemic has affected like the level of patients seeking out treatment, if that's decreased, or what kind of effect the COVID-19 has had on that.
Yeah, so the literature again is not, you don't have it out. It takes time for all the studies to come out. But what we have seen and what I've heard from others is the rates have gone up because of COVID-19. It was a stressor, so increased the rate of anxiety, depression, that in turn then increased the rate of substance use disorder. A lot of people did not have access initially, so there was lockdown. If they were using it, buying it from the street, drug was not available. The dealers, they could not contact them. So a lot of people had withdrawal, ended up and showed up in the hospitals. So the rate has increased. There's more problems. A lot of people using it because it came as a stressor. So people who are even sober for a while, they had relapses. Now we have tried to provide care to them, and now I think it's better since the lockdown was lifted. So a lot of people are coming in. And what we have done is shifted from in-person model to a telehealth model. So we try to reach out to them, and all the insurance companies initially had allowed, now they're changing their stance on it, but they had even allowed us to have a session over the phone. If we could not reach the patient, if the patient did not have a smartphone, they could not do a video session, do a telephone session, get the medication to them. So yes, the rates went up, but also we were able to reach those patients and provide care because of the availability of other ways like telephone session and telehealth.
Thank you.
Any more questions from the gallery? Okay, if not, let's all show ourselves and thank our speakers so much for an interesting and engaging talk. Dr. Ashraf, thank you once again.
Thank you.
Take care, everybody. There's a student seminar at 1 o'clock being hosted by the Neurosurgery Research Group. Shelley, would you like to say a couple words about that really quick?
It's SD Gretchen Kohler that will be presenting at 1 o'clock, and she is part of the NRG neuroscience group, as Dr. Staudinger was saying. So she has collaborated with us to present on behalf of NRG at 1 o'clock. So please join us.